Hello everyone, welcome back. Gram-positive bacterial infections continue to be a major challenge in hospitals, especially in the ICU. The emergence of MRSA, VISA, VRSA, and vancomycin-resistant enterococci has significantly limited our treatment options. Fortunately, several newer antibiotics have expanded our therapeutic arsenal. However, each agent has unique pharmacology, spectrum of activity, advantages, and limitations. In today's video, we'll discuss the most important newer antibiotics active against gram-positive bacteria, their indications, dosing pearls, adverse effects, and practical clinical applications. Let's begin. Resistance continues to increase worldwide. Major problematic pathogens include methicillin-resistant Staphylococcus aureus, vancomycin intermediate Staphylococcus aureus, vancomycin-resistant Staphylococcus aureus, vancomycin-resistant Enterococcus, and resistant coagulase-negative Staphylococci. Limitations of vancomycin include slow bactericidal activity, poor lung penetration, nephrotoxicity, therapeutic drug monitoring, and reduced efficacy when minimum inhibitory concentration approaches 2 mg per liter. These limitations led to the development of newer agents. Important drugs include: Number 1. Ceftaroline. Perhaps the most unique antibiotic. It is the only cephalosporin with reliable MRSA activity. Active against methicillin-resistant Staphylococcus aureus, methicillin-sensitive Staphylococcus aureus, Streptococcus pneumoniae, and Streptococci. Also retains activity against many gram-negative organisms but not Pseudomonas. Indications: community-acquired pneumonia, complicated skin and soft tissue infections, off-label MRSA bacteremia, endocarditis, salvage therapy for persistent MRSA bacteremia. It has excellent safety profile. Number 2. Daptomycin. One of the most important bactericidal agents. Disrupts bacterial cell membrane, causing rapid depolarization. Advantages: it has rapid bactericidal activity, excellent against methicillin-resistant Staphylococcus aureus, VRE, methicillin-sensitive Staphylococcus aureus, and resistant Enterococcus. Clinical uses: MRSA bacteremia, right-sided endocarditis, persistent MRSA bacteremia, and VRE infections. Major limitation: never use daptomycin for pneumonia. Pulmonary surfactant completely inactivates daptomycin. Monitoring: monitor creatine phosphokinase weekly because of possible myopathy. Tedazolid belongs to oxazolidinone class. Excellent oral bioavailability, almost 95%. Active against methicillin-resistant Staphylococcus aureus, VRE, and Streptococci. Major clinical uses: MRSA infections, VRE infections, and skin and soft tissue infections. Linezolid penetrates lung tissue extremely well, making it superior to vancomycin for certain MRSA pneumonias. In comparison to linezolid, tedazolid has less thrombocytopenia, once daily dosing, shorter treatment course, and fewer drug interactions. Lipoglycopeptides include dalbavancin, oritavancin, and telavancin. Think of these as improved vancomycin. Dalbavancin. Half-life around 14 days. Can be given as 2-dose regimen. Excellent for outpatient therapy. Useful for skin infections, osteomyelitis, and selected bacteremia cases. Ordivancin. Even broader activity. Covers methicillin-resistant Staph aureus, VRE including Vanna phenotype. Long half-life. Single-dose therapy. Telavancin. More potent than vancomycin against methicillin-resistant Staph aureus. Useful for hospital-acquired pneumonia, complicated skin infections. Limitations: nephrotoxicity, QT prolongation. Avoid during pregnancy. Lefamulin. A relatively newer pleuromutilin antibiotic. Active against methicillin-resistant Staph aureus, streptococci, and atypical organisms. Approved mainly for community-acquired pneumonia. Available in both oral and intravenous formulations. Let's simplify. Methicillin-resistant Staph aureus pneumonia. Preferred: linezolid. Alternative: vancomycin. Avoid: daptomycin. Methicillin-resistant Staph aureus bacteremia. Preferred: daptomycin, vancomycin, ceftaroline. Persistent bacteremia may require daptomycin plus ceftaroline. Vancomycin-resistant enterococci. Preferred: linezolid, high-dose daptomycin, tedazolid in selected situations. Skin and soft tissue infection. Dalbavancin, ordivancin, linezolid, tedazolid and ceftaroline. Osteomyelitis. Dalbavancin, daptomycin and linezolid, depending on susceptibility. Several promising agents are becoming increasingly available. Delafloxacin, active against MRSA and gram-negative organisms. Omadacycline, iravicycline, icloprim, new long-acting lipoglycopeptides under investigation. The future is moving toward long-acting outpatient antibiotics, improved tissue penetration, and better antimicrobial stewardship. Remember these important points. Ceftaroline is the only beta-lactam active against MRSA. Daptomycin is excellent for bacteremia but should never be used for pneumonia. Linezolid is preferred in many MRSA pneumonias because of superior lung penetration. Dalbavancin and ordivancin offer convenient long-acting therapy with once-weekly or single-dose administration. Tedazolid offers similar efficacy to linezolid with fewer hematologic adverse effects. Most importantly, always choose antibiotics based on culture reports, MIC values, site of infection, pharmacokinetic pharmacodynamic principles, patient-specific factors, and your local antibiogram. Antimicrobial stewardship remains the cornerstone of preserving these valuable agents. Thank you for watching. If you found this video helpful, please like, share, and subscribe to the channel. Don't forget to press the notification bell so you never miss our upcoming evidence-based critical care videos. In the next video, we'll discuss another interesting evidence-based topic. See you in the next video. Stay safe, keep learning, and practice evidence-based medicine.